Welcome back to the IJGC monthly IJGC Conversations, September Editor's Choice. We are diving into some recent publications that caught our eye. I'm Filippo Maria Capomacchia from Candiolo Cancer Institute, Italy.
And I am Natalia Teixeira from Hospital Clínic de Barcelona in Spain. Always great to dive into the latest research.
Yes, definitely. It's great to be back, and we've got a fantastic lineup of articles today. We'll be starting with a crucial lead article outlining comprehensive guidelines for managing gynecological cancer during pregnancy, followed by three fascinating editor's choice selections that explore novel treatments and management strategies for specific gynecological malignancies. Our first article and our lead for this episode is titled ESGO INCHIP Guidelines for the Management of Patients with Gynecological Cancers During Pregnancy. The author is Frederic Amant from the Department of Oncology at the Catholic University of Leuven in Belgium.
This paper really stands out as a critical resource, especially given how challenging it must be to manage cancer when pregnancy is involved. Can you elaborate on the main objective of these guidelines and who they are intended to help?
Of course, the ESGO, along with the INCHIP, developed these to provide comprehensive, evidence-based guidance for pregnant patients and their healthcare providers on managing gynecological cancers during pregnancy. They updated previous guidelines from 2009, 2014, and 2019, incorporating new evidence and covering new topics to ensure a multidisciplinary approach. The goal is to optimize treatment benefits for the mother while minimizing harm to the fetus, aiming for a prognosis similar to non-pregnant patients. They're intended for a wide range of specialists, from gynecologic oncologists and obstetricians to pathologists, radiologists, and even patient representatives.
That's a truly multidisciplinary effort, which is so important here. I noticed the methodology mentioned an international development group, including 21 experts from relevant disciplines and 2 cancer survivors, and that they conducted a systematic search for evidence. Why do you think it was particularly important for them to involve patient representatives and such a broad international panel in the developing of these guidelines?
That's a great question. Involving cancer survivors directly in the development group brings in the crucial patient perspective. Answering the guidelines address not just clinical efficacy, but also the real-world impact on quality of life and patient preferences, which are explicitly mentioned as considerations in counseling. As for the broad international panel and subsequent review by 100 independent international practitioners from Asia, Europe, Africa, and North and South Americas, it reflects the acknowledgement that there's a broad variability in clinical practice worldwide due to differences in infrastructure, resources, and cultural aspects. This inclusive approach aims to create guidelines that are as globally applicable and feasible as possible, while still emphasizing that clinicians should be independent medical judgment.
Yes, that makes a lot of sense, especially considering the rarity of gynecological cancers in pregnancy, affecting only about 2 to 5 per 100,000 pregnancies. What were some of the key takeaways or general recommendations regarding treatment strategies and diagnostic approaches that stood out to you?
A few things really caught my eye. Firstly, the emphasis on a multidisciplinary team discussion for staging and treatment is paramount. Secondly, a critical point is that pregnancy itself does not worsen the prognosis of gynecological cancers, which supports pregnancy-preserving treatment when possible. For diagnostics, ultrasound and MRI are the preferred safe imaging techniques during pregnancy, and they specifically recommend against using gadolinium-based contrast agent for MRI due to fetal risk. On the treatment front, they state that pregnant women should receive oncologic treatment as close as possible to the standard care for non-pregnant patients to ensure optimal maternal outcomes. For chemotherapy, it's generally not recommended before the 12th week of gestation, and careful timing is advised for later trimesters to avoid hematopoietic suppression in the newborn. They even specify that carboplatin is preferred over cisplatin in most gynecological malignancies due to the risk of ototoxicity in the newborn.
Those are certainly vital considerations. And speaking of the newborn, what did the guidelines suggest about fetal monitoring and pediatric follow-up after treatment?
They recommend fetal monitoring both preoperatively and postoperatively. Crucially, children exposed to cancer treatment in utero need examination by a neonatologist and screening for tracing neonatal myelosuppression, especially if the last chemotherapy course was close to birth. Long-term toxicity monitoring programs are also recommended based on specific treatments, such as monitoring hearing function after platinum-based chemotherapy and cardiotoxicity after anthracycline exposure. And a practical tip for new mothers: breastfeeding should be avoided if systemic anti-cancer therapy is required postpartum. It's truly comprehensive. Moving on, this next article connects nicely to our discussion on treatments.
The second article we're discussing is titled Preclinical Activity of Sacituzumab Govitecan in TROP2 positive low-grade serous ovarian cancer patient-derived xenograft models. The author is Victoria Etorrea, affiliated with the Yale University School of Medicine, Department of Obstetrics, Gynecology, and Reproductive Sciences in New Haven, US.
This sounds really promising. Low-grade serous ovarian cancer is not susceptible to traditional chemotherapy, isn't it? What's the unmet medical need that this study is trying to address?
You're absolutely right, Filippo. Low-grade serous ovarian cancer is a rare subtype of epithelial ovarian cancer, representing only 2 to 5% of cases, and it's characterized by an indolent growth but a high rate of chemoresistance. Many patients are diagnosed at advanced stages and will experience disease recurrence. Standard treatments like surgical debulking, carboplatin paclitaxel chemotherapy, hormonal therapy, and MEK inhibitors often lead to progression, leaving a significant unmet medical need for more effective, personalized treatments. This study aims to fill that gap.
So they looked at TROP2 as a potential target. What did they find regarding its expression in low-grade serous ovarian cancer, and how did they test the efficacy of sacituzumab govitecan?
This is where it gets really interesting. They evaluated TROP2 expression in 26 patients with low-grade serous ovarian cancer and found that all 100% showed expression of TROP2, with a remarkable 81% demonstrating moderate to strong expression. This is the first time TROP2 expression levels in low-grade serous ovarian cancer patients have been specifically characterized. To test STAC-GOV, which is an antibody-drug conjugate, or ADC, that targets TROP2, they established patient-derived xenograft models in mice using tumor tissue from a patient whose low-grade serous ovarian cancer was resistant to multiple prior treatments, including chemotherapy, aromatase inhibitors, and MEK inhibitors.
That's a robust preclinical model. What were the key results from their in vivo studies with sacituzumab govitecan? Did it show significant activity against these resistant tumors?
The results were quite compelling. In the mouse models, sacituzumab govitecan significantly inhibited tumor growth compared to the control group, with differences as noticeable as early as day 4 of treatment. By day 24, mean tumor volume in the treated mice was about 0.24 cubic centimeters compared to 1 cubic centimeter in controls. More impressively, the median survival for control mice was 22 days, while it was not reached by the end of the 50-day experiment in the sacituzumab govitecan treated group, as all mice remained alive. Importantly, they noted no significant weight loss in the treated mice, suggesting good tolerability.
Those are incredibly encouraging preclinical findings for a cancer with such high chemoresistance. What are the implications for clinical practice and what's next for this research?
The implications are significant. This study strongly suggests that TROP2 could be a viable biomarker-directed treatment option for low-grade serous ovarian cancer. Given that sacituzumab govitecan is already FDA approved for triple-negative breast cancer, its potential application in low-grade serous ovarian cancer is exciting. The authors explicitly call for further prospective clinical trials to confirm these findings and support its incorporation into clinical practice, especially for patients who have exhausted standard treatment options. It's a major step towards personalized and more effective treatment strategies for low-grade serous ovarian cancer. Now, while sacituzumab govitecan shows great promise, like all powerful therapies, it comes with side effects. Our next article really delves into how we manage one of the most common ones.
Our third article shifts focus to managing treatment side effects. It's titled Oral Mucositis Associated with Antibody Drugs Conjugates in Gynecologic Oncology, Strategies and for Prevention and Treatment. The first author is Michelle Lightfoot, affiliated with the Perlmutter Cancer Center in New York, USA.
This is such a critical topic. ADCs are revolutionary, but toxicities can really impact the patient's quality of life and even their ability to continue treatment. Can you explain why oral mucositis is such a notable on-target off-tumor toxicity, especially with TROP2 targeting ADCs like the one we just discussed?
Absolutely, it's a huge concern. ADC combine a targeted antibody with a potent cytotoxic agent aiming for specificity. However, on-target of tumor toxicity occurs when the target antigen, like TROP2, is also expressed in healthy tissues. This review highlights that TROP2 is highly expressed in the oral mucosa and proximal digestive tract, which explains why TROP2 targeting ADC such as sacituzumab govitecan and datopotamab deruxtecan are frequently associated with gastrointestinal adverse events, including oral mucositis or stomatitis. While sacituzumab govitecan is more often linked to diarrhea, datopotamab deruxtecan frequently causes stomatitis. When mucositis happens, it can significantly impact quality of life, hinder nutritional intake, increase infection risk, and lead to dose delays or even discontinuation, ultimately affecting cancer treatment outcomes.
That's a clear explanation of the mechanism. So, given its impact, what are the primary strategies that they recommend for preventing oral mucositis in patients receiving these ADCs?
The review emphasizes routine symptom monitoring and basic oral care like brushing twice daily and flossing. For agents with a mucositis incidence of 20% or higher, they recommend prophylactic measures. This includes using a steroid-containing mouthwash 4 times a day, bland rinses, and potentially mucoadhesive gels. Topical antifungal prophylaxis might also be considered. Another key prophylactic measure, especially for some chemotherapy regimens, is cryotherapy, by holding ice chips in the mouth for 30 minutes before and during the infusion.
And if mucositis does develop, what are the recommended management strategies based on severity?
The management is graded by severity. For grade 1 mucositis, patients should adjust their diet to avoid acid, salty, or hard foods and abstain from alcohol and tobacco. Symptomatic relief can come from 2% viscous lidocaine or formulated mouthwashes. If it progresses to grade 2, they recommend adding empiric oral fluconazole and holding the ADC treatment until symptoms resolve to grade 1 or less. For grade 3 or higher, which is severe, they suggest a 2% morphine mouthwash for analgesia, referral to an ENT specialist, and considering a short course of systemic steroids and systemic analgesics. Treatment should be held until resolution to grade 1 or less, and a dose reduction of the ADC should be considered. In very severe cases, hospitalization for hydration and pain control might be necessary.
That's very practical guidance. It's also interesting that they mention several therapies not yet recommended for chemotherapy-induced oral mucositis, like photobiomodulation, benzidamine, KGF1, glutamine, and honey. It highlights that while these might be useful in other contexts, evidence is still lacking for ADC-related mucositis.
Exactly. It underscores the need for more targeted research on ADC-specific toxicities. This leads us perfectly into our final article, which discusses another challenging gynecological malignancy.
Yes, our last article for today is titled Uterine Leiomyosarcoma. The author is Giorgio Bogani from the Fondazione IRCCS, Istituto Nazionale dei Tumori di Milano, Department of Surgery in Milan, Italy.
Uterine leiomyosarcoma is quite a formidable disease. What are the key challenges in diagnosing and treating it, especially given its rarity?
It's indeed one of the most aggressive and lethal uterine malignancies, representing only 1 to 3% of gynecological cancers, with a poor 5-year survival rate of approximately 40%. The main challenges stem from its non-specific clinical presentation, often mimicking benign conditions like uterine fibroids. There are no definitive serum markers or radiological criteria to reliably differentiate ULMS from benign leiomyomas preoperatively. This frequently leads to delayed diagnosis, often made only after surgical resection. This diagnostic complexity underscores the importance of a high index of clinical suspicion.
That's a significant hurdle. So, how is uterine leiomyosarcoma typically diagnosed and staged? And what about the critical point of avoiding morcellation during surgery that's often discussed?
Pathological diagnosis is crucial, relying on a combination of morphologic assessment and immunohistochemistry. The three hallmarks for ULMS diagnosis are moderate to severe cytologic atypia, tumor cell necrosis, and mitotic index of 10 or more per 10 high power fields. Regarding imaging, pelvic ultrasonography and MRI are initial modalities for diagnosis and assessing local spread, while contrast-enhanced CT of the chest, abdomen, and pelvis is recommended for staging distant metastases. And yes, the article strongly states that morcellation should be strictly avoided in cases with preoperative suspicion, due to the very real risk of spreading malignant cells. This can drastically impact prognosis.
That's a vital piece of information. What are the current standard primary treatment approaches for both localized and advanced uterine leiomyosarcoma?
For localized disease, so FIGO stage 1, the cornerstone and only curative option is complete surgical resection, typically an en-bloc total hysterectomy with or without bilateral salpingo-oophorectomy, depending on menopausal status. Post-surgery, observation is generally the standard approach. The article specifically mentions that adjuvant radiotherapy is not indicated, and the benefit of adjuvant chemotherapy in stage 1 disease remains unclear due to limited evidence. For advanced or metastatic disease, so FIGO stage 2 to 4, a comprehensive multimodal approach is recommended, involving surgery, systemic chemotherapy, and/or radiotherapy. If complete cytoreduction is achievable, surgery is prioritized. If the disease is initially unresectable, primary systemic therapy, typically doxorubicin-based regimens, or palliative radiotherapy is advised.
And what about recurrent disease and the newer targeted therapeutic agents being explored?
Managing recurrent ULMS is very challenging and requires a tailored approach, often involving further surgery if resectable or systemic therapy if unresectable or disseminated. For systemic therapy in recurrent settings, options include trabectedin, panzopanib, and gemcitabine plus docetaxel. What's exciting are the novel therapeutic agents under investigation. These include anti-angiogenic agents like pazopanib, immune checkpoint inhibitors such as pembrolizumab, particularly for tumors with high tumor mutational burden, and even HER2 targeting agents like trastuzumab deruxtecan, though data for ULMS is still limited. Also, PARP inhibitors are being explored for BRCA mutated or homologous recombination deficient ULMS.
It's fascinating how precision oncology is starting to carve out paths even for rare and aggressive cancer like uterine leiomyosarcoma. It really underscores the importance of ongoing research and patient participation in clinical trials.
Absolutely, Filippo. These four articles really highlight the breadth of advancements and ongoing challenges in gynecological oncology. From setting comprehensive guidelines for pregnant cancer patients to exploring novel drug therapies and optimizing management for rare, aggressive cancers like uterine leiomyosarcomas, the field is constantly evolving.
Indeed, the common thread across these discussions is the absolute necessity of multidisciplinary collaboration and patient-centered care. whether it's balancing maternal and fetal outcomes, managing difficult side effects from cutting-edge ADCs, or navigating the complexities of uterine leiomyosarcoma, a team approach and prioritizing the patient's overall well-being are consistently emphasized.
And for our listeners, we hope this deep dive has provided a clear understanding of these complex topics. The call for further clinical trials and global collaboration is loud and clear in all these papers, pushing towards more personalized and effective treatments.
A huge thank you to Natalia for such an insightful conversation, and thank you to all of our listeners for tuning in. We encourage you to seek out these excellent articles for more in-depth information. You can find them in the International Journal of Gynecological Cancer.
My pleasure, Filippo, and thank you to all our listeners for tuning in.
Thanks for joining us, and we'll catch you next time.
Bye, everyone. We'll be back soon with more updates from the IJGC.